Devices, Infection Control and Nutrition, Section 5 of 6. Comparison of peripheral inserted central catheter materials. We'll look at the sticky trial. We'll look at 7 versus 14 days of antibiotics for gram-negative bloodstream infection, stress ulcer prophylaxis in tracheoinnominate artery fistula, target protein randomized clinical trial. This is the nutrition part, and the glycemic control, 2024 in critical care medicine, and the potassium iodine for thyroid storm, and 4% tetrasodium EDTA. So a hodgepodge of articles here. Coded versus standard PICC lines. Picnic trial looked at chlorhexidine versus hydrophobic versus standard polyurethane PICC lines. Basically higher complication rates with chlorhexidine. So yes, chlorhexidine PICCs have been studied and did not demonstrate any improvement. Standard PICC lines are the standard of care. Liquid adhesive, there is a medical liquid adhesive under the standard dressing that decreases the rate of dressing failure. So there's going to be a larger trial needed for infection and catheter loss outcomes. This is published in the Critical Care Medicine 2025. What is a catheter lock solution? That is a solution that's instilled into the catheter lumen between uses, not infused into the patient. It sits in the line to prevent clot formation, biofilm, bacterial colonization at the catheter tip. Standard locks are saline or citrate. Tetrasodium EDTA adds an anticoagulant, adds an antibiofilm. It is never enters the systemic circulation. It's like corking a bottle between the pores. And that was looked at, randomized control trial in JAMA 2026 versus control, and basically lower composite rate of occlusion, thrombosis, or CLABSI, but it was driven mostly by fewer alteplase infusions. For occlusion, you could see here 18 in the control per 1,000 catheter days versus 12. Antibiotic duration for gram-negative bacteremia, the BALANCE trial, New England Journal of Medicine 2025. 7 versus 14 days of IV antibiotics for bloodstream infection, excludes immunocompromised prosthetic valves and Staph aureus bacteremia. And the meta-analysis confirmed no mortality difference. The 90-day mortality was not significantly different between 14 days and 7 days. The 7 days were sufficient for uncomplicated gram-negative bacteremia. Guidelines for ECMO cannulation site infections now are out there. Save ECMO, intensive care medicine. And ECMO cannula site infection is pathogen isolation, purulent discharge. This is the first consensus definition, diagnosis prevention framework for ECMO, CSI. Don't change intact chlorhexidine dressing for 7 days. Stress ulcer prophylaxis, the revised trial, New England Journal of Medicine 2024, proton pump inhibitor versus placebo in patients at high risk for upper GI bleed, mechanical ventilation patients. No impact on mortality, but relative risk 0.51 for upper GI bleed versus placebo. So stress ulcer prophylaxis recommended. Critically ill patients at high upper GI bleed risk, look at the 4% risk placebo versus PPI 1%. Clinically significant upper GI bleed. Tracheoarterial fistula, published in the Otolaryngology Head Neck Surgery 2025. Rare, but is often fatal. Only 50% present with a classic sentinel bleed. CT is more sensitive than bronchoscopy. Temporized with cuff overinflation, and it's typically 6 to 8 weeks after tracheostomy. There's the innominate artery, and that is the one that could fistulize with the trach. And you would do typically sternal notch pressure before repair. How about protein and nutrition? So high versus usual protein feeds. Similar 90-day survival. 2 grams per kilogram per day was compared to 1.3 grams per kilogram per day. Higher dose was lower quality of life at 180 days. 1 to 1.5 grams per kilogram per day, a protein remains sufficient. That is the target trial, JAMA 2025. And then the SCCM guidelines came out on hyperglycemia management. Hasn't changed much. Target is 140 to 200. Liberalized the glucose targets versus the 2012 guideline. At least hourly checks, and the emphasis is on avoiding hypoglycemia. New treatment for thyroid storm, potassium iodine. KI within 2 days of admission, shorter length of stay. Mortality in Graves' disease was about half if you're given KI plus thionamide. So, picnic trial, chlorhexidine versus the standard pick. Chlorhexidine had more complications. Sticky trial, what was the effect of the liquid adhesive? Reduced failure at 7 days from 50% to 28%. Balanced trial, same. 7 days was non-inferior. Revised trial. PPI, reduced upper GI bleed. Tetrasodium EDTA, catheter lock, main benefit. Fewer alteplase infusions. Ideal protein dose for ventilated patients, 1 to 1.5 grams. And then the last 8 practice updates, we'll look at systems, ultrasound, and end-of-life care. We'll look at POCUS on clinical outcomes, patients with shock, diagnostic errors, patients transferred to the ICU, the telescope trial, tele-ICU, Society of Critical Care Medicine practice guidelines, end-of-life care, and then ventilator withdrawal at the end of life, and defining time-limited trial, as well as tele-rehab on mechanical ventilated patients. So the first one is critical care ultrasound SCCM guidelines, critical care 2025, vasoactive medication duration less 7.3 days, 28-day mortality, cardiac arrest. There was no recommendation either way. Borderline significance for kidney replacement therapy. Diagnostic errors in hospitalized patients. We looked at structured review of ICU transfer diagnostic accuracy, published in JAMA Internal Medicine. Errors judged to have contributed to harm or death in most cases. And we are talking supports investment in diagnostic safety programs. 23% of ICU transferred patients experienced a diagnostic error, which is pretty high. Critical care telehealth telescope trial, remote daily multidisciplinary rounds by board certified intensivists plus monthly feedback meetings, no reduction in mean ICU length of stay. You tailor the telehealth to local conditions. Greater than 17,000 ICU patients, no length of stay benefit from telecritical care rounding. Updated ICU end-of-life care guidelines, 2025, structured communication tools and shared decision-making, meeting templates, web-based decision aids, clinical education, and institutional protocols. So what they did is structured ICU family meeting, understand, explain, elicit values, recommend, decide, document, reassess. So a structured communication plus shared decision-making with families and surrogates. This is where you can find these guidelines and know that they exist, and we can get better at communicating with patients. Understand, explain, elicit values, recommend, decide, document, reassess. And then there's family caregiver support guidelines. This is to prevent post-intensive care syndrome, family PICS. F, strong recommendation for liberal family caregiver presence, includes presence during rounds and resuscitation, dedicated family space, conditional recommendation for enhanced communication support, gradual versus one-step withdrawal on the ventilator. This is in Journal Palliative Care Medicine. Should you do gradual weaning or one-step? And the answer is gradual weaning is preferred for most patients undergoing withdrawal. One-step may suit select patients, but gradual weaning was less respiratory distress. And then the ATS definition of a time-limited trial, Annals of American Thoracic Surgery. This is a collaborative plan with clinicians, defined duration, followed by reassessment of response, 16 core elements, 4 phases: consider, plan, support, and reassess. This is interesting. Telerehab after critical illness, randomized controlled trial. We're looking at 329 patients, 6-week remote rehab versus standard care after 2 days of ventilation. And similar health-related quality of life at 8 weeks, improved strength, exercise capacity, anxiety. 90-day mortality was higher in the usual care compared to the telerehab. So this would lean towards telerehab after critical illness. Telescope trial. Does telecritical care reduce ICU length of stay? No. Percentage of ICU transferred patients with a diagnostic error? About 25 to 30%. 23%. SCCM recommendation on family presence in the ICU? Yes. Gradual versus one-step withdrawal at the end of life? Gradual. ATS time-limited trial phases? Consider, plan, support, reassess. And the ultrasound guideline conditional recommendation in septic shock, respiratory failure. Cardiogenic shock is actually not so clear. Those are conditional recommendations. And that's it. Hopefully you learned something.